بسم الله الرحمن الرحيم. In this video, we will speak about emergency oxygen therapy. Oxygen therapy is either controlled or uncontrolled. Uncontrolled and the highest levels thought to be important, such as in shock, sepsis, major trauma, cardiac arrest during resuscitation, anaphylaxis, cardiac or sorry, carbon monoxide or cyanide poisoning, and pneumothorax. Uncontrolled and saturation values between 94 and 98. This is the second type of emergency oxygen therapy. Uncontrolled and saturation values between 94 and 98 are thought best. This will be used when extra oxygen is required to raise the saturation and there are no concern that high PaO2 values will depress ventilatory drive to the point that PaSO2 will rise and the pH fall dangerously, such as pneumonia, asthma, acute heart failure, pulmonary embolism. The third type, controlled use when extra oxygen is required, but ventilation critically depends on hypoxic drive, and there is a recommendation to keep auto saturation at 88 to 92%, such as in exacerbation of COPD, particularly when there has been a chronically raised PaCO2 as evidenced by a significant base excess, and the exacerbation of cystic fibrosis, in addition to exacerbation of ventilatory failure due to obesity, hypoventilation syndrome, or exacerbation of chronic ventilatory failure due to scoliosis, neuromuscular disease, and any other cause of pump failure. With stable type 2 ventilatory failure, ventilation still seems to be dominantly driven by PaCO2 and pH, but in exacerbations when PO2 usually falls, peripheral chemoreceptors drive from low PaO2 becomes dominant. Thus, autotherapy must not raise PO2 above 8 kPa, approximately 92% saturation, and this will turn off ventilatory drive, allowing hypoventilation, hypercapnia, acidosis, and potentially death. There is some evidence that a high alveolar PO2 also turns off hypoxic pulmonary vasoconstriction. This allows an increase in pulmonary blood flow to poorly ventilated areas and reduced CO2 excretion, accounts for about 20% of PCO2 rise following excessive FI2 in COPD exacerbations. There is increasing evidence that indiscriminate use of oxygen saturation in some medical emergencies may actually harmful and should only be used if the patient is hypoxic, that's to say below 94%, and then to achieve no higher than 98%, such as in ischemic heart disease, including MI, post cardiac arrest once stable, and sickle cell crisis, obstetric emergencies, and most poisoning other than carbon monoxide or cyanide, and metabolic or renal acidosis with short breath. Delivering uncontrolled oxygen. This can be done in many ways, essentially by blowing O2 over the face whilst limiting inhalation of surrounding air or exhaled CO2. Types of device include standard O2 face masks, sometimes called high flow masks, set the oxygen regulator to at least 4 liters per minute, much more if very bracelets to prevent dilution by air drawn into the mask by high inspiratory flow by exit holes. Can deliver about 50 to 60% of oxygen. Second, nasal cannula bronchoscopes are uncontrolled and deliver unpredictable levels of oxygen, depend on flow rate, minute ventilation, and oral versus nasal breathing. Titrate using an auto saturation monitor. Non-rebreathe reservoir mask can deliver FA2 values over 60% by means of a soft plastic bag between the end of the tubing and the mask, plus one-way valves between the bag and the mask and on the mask exit ports. This mechanism ensures that the most of inspired air is pure oxygen. Then very high flow FiO2 requires a tight seal and is generally dribbled with CPAP masks using pressure of about 5 to 7 centimeter H2O, and this ensures no air is entrained through blow-off vents or leaks, as well as improving VQ matching by requiring by recruiting collapsed alveoli. Delivering controlled oxygen therapy, this requires ability to reliably control the FiO2 in order to keep the patient's saturations below 92%, and some prefer below 90%, but high enough to prevent anaerobic metabolism. This lower acceptable level is adaptable, debatable, and 88% is generous, 85% likely to be adequate, and 80% may be acceptable. If cardiac output is adequate and the patient usual levels are around the figure. If I2 is controlled through Venturi masks, auto-saturate oxygen is directed through a narrow nozzle and exists at a speed, lowering the air pressure at the point, and this draws in surrounding air, diluting the oxygen. A proper Venturi mask mixes oxygen and air in the same proportion, regardless of the oxygen flow. The minimal flow setting of the regulator written on the nozzle ensure adequate overall flow to preventing diluting air being drawn through the exit holes during inhalation, such as a 28% Venturi mask has a 1 to 10 entrainment ratio, 1 liter per minute oxygen entrains 10 liter per minute air, total flow 11 liter per minute, 2 liter per minute oxygen entrains 20 liter per minute, total flow 22 liter per minute, and so on. Nasal cannula. Nasal cannula are definitely not controlled oxygen therapy and are in fact the opposite. If nasal cannula do deliver too high an FiO2 and ventilation decrease as a consequence, the proportion of the minute ventilations concentrating the fixed flow nasal oxygen will rise, increasing the FiO2 and hence PaO2 still further, a vicious cycle. Controlled O2 via low flows is also needed sometimes with NIV, but rarely requires more than 1 liter per minute to be entrained. Again, it should be titrated using the SaO2. When the patient on IV is still required to trigger inspirations, again add oxygen should be kept to minimum so as not to do depress ventilatory drive. When adding too much oxygen, it's easy to be lulled into a false sense of security by an saturation of oxygen values more than 92, while the PaO2 gradually rise undetected. As I said, O2 alert card should be given to all patients with a previous episode of hypercapnic respiratory failure and this alerts ambulance crews and medical staff to the potential risk of the hypercapnia with high flow oxygen and documents usual resting baseline saturation. However, some ambulance staff protocols are sufficiently rigid that they may not be allowed to override them, and in some areas, letters from the patient's consultant and the head of the ambulance service must be with the patient. We will stop at this point, then we'll continue video of home oxygen inshallah in the next video. Thank you.